I'm mic'd. I can't move.
Well, I do want to get started before Rebecca falls asleep, so a little jet lag, I imagine. So, welcome everybody. I'm happy to introduce Professor Rebecca Ivers from the George Institute for Global Health. She's director of their injury division. It's based at the university, and she's also professor of public health at the University of Sydney, and KidSafe New South Wales Council member and a board member of the Global Road Traffic Injury Research Network. She's a graduate of the University of Sydney with a Master of Public Health and a PhD in injury epidemiology. She directs a research program with a strong focus on prevention of injury from road traffic, also falls and burns in Aboriginal people, well over 100 peer-reviewed journal articles, chapters, and technical reports. She has expertise in the conduct of large-scale observational and intervention studies, data linkage and analysis of recently collected data. She's also an editor or editorial board member of 4 different injury or other research journals, which serve together, the Cochrane Injury Group, and please welcome
Thank you, and it's great to be here. I'm not really all that jet lagged, so I think I should be all right. So if my eyes start rolling back in my head, no. I'll just tell you a little bit, firstly, before I start, about the George Institute's a medical research institute at the University of Sydney. So we're a global organisation, and we have offices in Australia, but also in China and India, and in the UK at Oxford University as well. Most of our injury research is done in Australia, but we have had a reasonable amount of work done in China. We've done a big seatbelt intervention study and some novice driver work in China, and more recently in India, we've been doing work on the burden of injury in India, and we've actually got a study underway at the moment in northern India looking at the burden of injury, which is a study aimed at collecting information on functional outcome and disability post-injury. And again, that's a pilot study that's funded by the Road Traffic Injury Research Network, but again, we're trying to get funding for a larger scale study to expand that, because the results of that will feed into the into disability weights for the global burden of disease study estimate. So most of the work in India has been focused around that, but we've got a couple of grant applications in, one for the bigger study, but another one for a trial of yoga as an intervention to prevent falls in older people in India as well. And we've done pilot work developing a yoga-based intervention in India and showing that it does actually increase strength and balance. So mind you, with the funding in Australia being what it is, I'm not really holding my breath for that one, but we'll see. You never know. So most of our research, we have got a good proportion of research that is road safety based. So some of the recent work that we've done has been a big case control study of heavy vehicle drivers, looking at schedule impairment and sleep and risk of crash. We've done work on novice drivers. Got a big cohort study with 20,000 novice drivers, which I'm just about to apply for funding for a relinkage to 10-year outcomes for crash and injury and hospitalisation and death. We have got a study, an intervention study at the moment, looking at educational interventions to help older at-risk people stop driving, and that is a occupational therapy-based intervention, but we're also instrumenting their cars as well, so we've got really interesting GPS data from all these people enrolled in the trial as well to see where they're driving and their exposure. I'll talk tomorrow. I'm going to do another talk tomorrow on Aboriginal injury and the burden of injury, and I'll talk a little bit more about some of the work in that area. But in Aboriginal injury, we're working with, we're doing observational work, just looking at the burden of injury and crash involvement. We've got a big intervention study looking at driver licensing support for young Aboriginal people, falls in older Aboriginal people, and another really big study we've just had funded, which is looking at burns, where we're tracking Aboriginal children with burns across 4 states in Australia. So that's, again, another really exciting study. What I'm talking, though, today is about the child restraint work. This is work that we did in Sydney, as you can see, glorious place to live, but not quite as cold and windy as Denver, but I'm sure we do have serious bushfires and very hot weather as well, so it's not always fun again. I guess when you think about Australia, you often think about Sydney, you often think about the outback as well, and a lot of the work that we do is challenging in that context because we're working across very urban environments, particularly for our Aboriginal injury research, where we work in urban environments like Sydney, and then we have to go out to very remote places like this where we still do have a reasonable population. What we normally do, and this is just a habit that we get into, is to acknowledge the traditional owners of the land. This is a sort of recognising the Aboriginal custodians, and so I would like to acknowledge the Native American Indian custodians of the land here too and allowing us to meet here today. The Buckle Up Safety Program was one that we had funded by the National Health and Medical Research Council of Australia, so that's our big peer review funding source. And it was a study we ran from 2009 to 11, I think. And these are the investigators. So from a range of different institutions, the University of Sydney, and the RTA is the Roads and Traffic Authority of New South Wales State Transport Agency. And they were also investigators on this study, which was fantastic. They actually named investigators on grant and Neuroscience Research Australia. One of the important things about this study, and some of the work that we try and do, is that we try and involve the policymakers in our studies from the very beginning. So when we start writing the grant, we get them involved on the team at that point. So either involving them, if not, generally not as investigators, because when you're writing a grant, the investigators need to have the research track record, but if not, as an investigator, as an associate investigator, or named on the grant in some way so that they feel some kind of ownership over the program. And I think it has paid off for this one, but the reason why we do it is so that they feel more obliged, they're more interested in the research, we get that policy expertise feeding into the questions that we're asking, and it helps facilitate the conduct of the study, particularly with the road safety work, which, as you know, is often based on changes to legislation or sort of program delivery, and it hopefully helps with the dissemination of the outcome. In New South Wales, and probably similar to the US in many contexts, there's been a big change in the number of children that were restrained. So in the 1970s, we had high numbers of kids being killed and injured, lower levels of children restrained, and certainly in the 70s, the children who were restrained were only in seatbelts and not in child restraint. Now you see 1,500 killed and injured, but greater than 90% of children are restrained. Crash investigation studies have shown, and again, not rocket science, but basically children are optimally restrained in the right restraint and for their age, the risk of serious death and injury goes down, as the studies show. And Julie Brown is one of the investigators that's been working with this study. Community studies have also shown that, even in Australia, more recently, not that many children are actually in the right age-appropriate restraint or using it correctly. So this about 54% of people using the correct restraint, which is not really all that great. You can see with increasing age up to the age of about 8, and this is based on the concept that children need to be in a boosted seat until they're 8. So you see that rapid drop off at age 9. You'll see that most children were reported as being inappropriate at their age. We have also done a lot of observational studies, at least Julie Brown and Liz Wilson have, showing misuse. So even if kids are in the right age-appropriate restraint or the appropriate restraint for the height and weight, they still may not be using it correctly. So a high proportion, around half, were incorrectly using restraints. And this, again, seriously incorrect 38%. So with a loose or twisted harness, top tether, not anchored and armed at a harness. In Australia, our child restraints have got a top tether, so it's a slightly different system, but basically the top of the child restraint's got an anchor, a strap that goes through to an anchor, so they've got to be anchored down either from the roof of the car or an anchor point down the back. And then again, that's a really serious issue because it's very hard, when it comes to installation, moving seats around, it can be quite tricky moving that anchor point. You are reliant on having the appropriate anchor point. So understanding how much you're actually going to benefit you're going to get, some work that Wei-Du did, again, the researcher that Julie Brown and Bill showing that if you actually can get kids into the right age of appropriate restraint, you're going to get a big reduction in injuries. So 41% reduction in fatal injuries and 55% reduction in non-fatal injuries. So that's assuming 100% impact prevention. And you're never going to quite get that because you're never going to get people using restraint perfectly. In the US, it's similar. States with child restraint laws have 20% fewer deaths from age 4 to 8 years. And children in those states with those laws are more likely to be restrained, more likely to be correctly restrain. We had new legislation that was introduced in Australia. So again, for the context of our grant, we wrote it in 2009, and the grant was beginning of 2010. Unfortunately, even though we had the state government involved in the study, the legislation was brought out, was introduced, so that it just about coincided with the start of our grant, which actually gave us a few exciting moments when we thought about how we were going to do this cluster randomised control trial at the same time that the legislation was introduced. We did manage to get the timing almost right, which I'll show you in a figure later. But basically, the new legislation said that children younger than 6 months must be secured in a rearward-facing restraint, 6 months to 4 years in a rear or forward-facing restraint, and they're the ones with a 5-point harness, and then 4 to 7 years must be secured in a child restraint or a seat, with a few extra little rules there about children not being able to cover the front seat of the car, if there's still more rows. And there was a transitional period. So they brought it in from March, but they weren't going to start actually enforcing it until the beginning of July 2010. And really, before that, the legislation in Australia had been, in New South Wales certainly, had been that children under the age of 12 months needed to be appropriately restrained, and that was just about it. There weren't any kind of no restrictions on what type of restraint. People broadly believed that children up to the age of about 4 needed to be in forward-facing restraint, but actually it was the law. Restraint use was a lot higher than what you'd imagine for what the law actually was. Okay, so what are the predictors of suboptimal restraint? When we started looking at this, so where this study actually came from was that I'd actually been to looking at multiple papers and been at multiple meetings where people had talked about the need about child restraint issues, but there hadn't been any intervention studies apart from the one that Carolyn and colleagues had done here in Colorado, trying to understand how you actually can get kids into restraint. So we knew that restraints were really good and that we needed to get more children into appropriate restraints. What the issue was how are we actually going to do that? So that was the question that we were trying to ask. So if you look at the predictors of suboptimal restraint use, research was showing us they relate to family characteristics, parental education, low income status, large family size, and non-English speaking at home. And you'll often find that the optimal restraint use is lower in areas with low socioeconomic density, so with more people of low SES. And there are a lot of barriers, so misinformation and confusion. We had done some qualitative work in community settings around the same time. Misinformation confusion was certainly something that was right out there. Lack of understanding of how child car seats work and why they're needed. Concern over convenience, how hard it was going to be to get the child restraints in cars, and logistics. So we had a lot of people that we talked to who had multiple children and vehicles, particularly people from lower income backgrounds who were sharing lifts with other families, and so needed to be able to move their kids from car to car, and were sort of going, well, we don't know how we're going to do this. I don't know that we had the answers for that, but certainly that's been there to be some of the things that have been raised, particularly from Aboriginal families who often don't have a private family vehicle, but they're often sharing lifts. So it's hard to actually travel with a child restraint with you that you need to reinstall in every car that you're in. So what's the research say about how we can increase this? Well, educating parents around how restraints work and the right restraint for age, involve peers and community, so peer-led education and involving the community, providing hands-on demonstration, and subsidies and distribution of restraint. And I think there's a bit of evidence that shows that you don't want to give restraints out for nothing. People need to be paying something for them, so they ascribe some value for them. There's also a Cochrane review, and so reviews of 5 randomised clinical trials of interventions to increase child restraint use, education, distribution, and education and incentives had the biggest impact. Carolyn's group had also done a cluster randomised control trial looking at staff training and parent sessions delivered at preschools in Colorado. And you handed out this to see, so just completely interrupt me if I've got anything wrong there, Carolyn. Low uptake in minority groups, and there was an 18-month, the intervention was implemented over 18 months. And we did have a good chat to Carolyn and to Sally Thorson about this before we put our intervention in place, because we wanted to make sure that we learnt from what they had learnt in the identifying what the issues were. One of the issues were in the preschool, in the settings, were that there was the problems with staff turnover. So when you have high staff turnover, you build the capacity and then the staff leave and you've got to start from scratch again. So it's very hard to actually get reinforcement of messages. And they found an increase in knowledge, but no difference in restraint over time. So our aim was to increase the use of the correct child restraint for age, but also to reduce misuse of child restraints. And we decided to put in place an intervention that targeted parents, teachers and the children using education, demonstration and distribution of restraint. Now, it was based on a behaviour change model. I have to say I didn't design this. I'm an epidemiologist and I always poo-poo these kind of theoretical models, but I have been I've sort of had the model forced onto me, but I think it does make a lot of sense. And so we were looking at this precaution adoption process model. So the aim is to look at the different stages that people are at, so whether they're unaware of the issue, unengaged, whether they're decided to acting, and then maintenance. And as you put it in, you see along here, we put in the intervention at the stage between unaware and engaged, so the education and motivation. And for people that did want to get the right restraint, giving them the opportunity to get a restraint installed in their car. What we worked on was a program where this is the design. It was a cluster randomised control trial. We had 28 centres, and we had the issue of the new legislation to fit in here around. Now, fortunately, they put it in place in March. We just had time to get our surveys done before the legislation came in. So across all of the centres, we did a self-report survey of families attending centres. So basically, we had a trained group of research assistants that went around to all of the centres and basically administered a self-report survey to all the parents before the legislation came in, so that we got a good baseline before intervention. We got that done at all of the sites. I think there might have been a couple that got the survey just after March 1st, but because there hadn't been widespread marketing, we didn't think that was a big issue. But generally, we got them all done before the legislation came in. Once they'd done the survey, then we assessed the baseline characteristics of all the centres so we could balance the randomisation. Did a randomisation process, so we had 14 intervention and 14 control. We basically did this in low-income areas of southwestern Sydney. So we used the CEPA index, which is a Bureau of Statistics index, which basically looks at postcode and income and education and occupation based on census data. Looked at areas that were basically in the lowest quartile of the CEPA scale. We had to have centres that had more than 20 families with children aged 3 to 5. They had to have a suitable location, so they had to have a car park where we could make safe observations as well. And of the centres that we selected, we had an 82% response rate. So we actually had pretty good representation of the centres in that region. So we had little bias in terms of actually the centres that were recruited to study. We balanced the randomisation by service type, preschool versus long daycare centre, self-reported appropriate restraint use, family speaking languages other than English at home, the household income and the number of enrolments. So we had no more than 10% difference in the answers of both of those, otherwise 5%. So the timelines were, we did the intervention over a year, and so we learned from the Colorado trial, which is that we implemented the intervention over 1 year. Also with preschools and long daycare centres, they're very much focused on calendar years because children come into the centre for a 1 year period and then they move off to school. So we wanted to make sure we were going to actually do it within a 12-month period. It does have an impact on what the long-term impact is going to be, but really at the end of the day, we were just interested in seeing what we pragmatically could do in a 12-month period. So we had to move pretty quickly. We did the parent survey, randomisation, and then we ran staff workshops, and I will talk to you about what the intervention was in a minute, parent sessions up until about September, and then we did the survey use towards the end of the year. The control sites then got the program offered to them and they were able to have that implemented at their centre for following. The program was basically based on 3 things. One, we worked with Kids and Traffic, which is a New South Wales government-funded centre which delivers road safety resources to preschools. So they go in, they develop all these resources like this one you see here out and about. They deliver that to preschool teachers and give them curricula about that they can build into their programming for children. So they developed this curricula for preschool staff and they ran these training sessions. It was only focused on child restraint use and they gave them a whole lot of curriculum ideas, including things like teddy bears in boxes, with making seatbelts, talking to children and families, and also policy support for the programs, songs and games that they could play with the children. And they developed some great resources. There were 13 workshops, and they also provided ongoing program and policy support for the staff. So once, if you're involved in kids and traffic, basically they come in and deliver the program, but they'll also keep continuing to send you resources. They also sent the centre preschools directors information that could go into the preschool newsletter to parents. So they were consistently getting messages about child restraint. So the teachers were delivering this curricula to the kids, but there were also messages about child restraints going home in the newsletter, and there were posters up around and all the activities that the children were around in the centre. We did have a few discussions with Kids and Traffic about this, because one of their policies is that you don't get children to take responsibility for things like road safety and child restraints. But again, it was aimed at trying to allow get the kids to be more supportive of the child restraint use when their parents were sort of foisting on them. So, but it wasn't directed at getting the kids to say, "Mum, you have to put me in a child restraint." It was more about making them feel more comfortable with it. But a little bit of a philosophical debate with them about that. But they were very happy in program in place. And you can see these are some of the content. So some of it was based around numeracy and passenger safety, and some of the literacy things. And they put up things like what kind of child seat are you in, and then kick off with the kids. This is a preschool in one of the centres, and they're sort of playing games and doing the sort of various activities that were involved in the child restraint. It was very well received by the centres and by the parents. This is some of the program print material that we developed. The second stage of it was doing a workshop to parents. So we actually then had an afternoon tea with parents where we sat down and we went through why you need to use restraints. This was delivered by one of the staff members from Kids and Traffic, again, because we wanted to actually build a program that was going to be sustainable and offered by, routine services, and that's their job, to go out and deliver these kind of programs. This was taking it to the next level. They don't normally do parent workshops, but we trained one of their presenters, and she went out and delivered all these parent workshops where she basically talked to them, gave them all the print material. They all got a little goodie pack which had all this material in it, and also a DVD explaining why you need child restraints. We translated all the study material into the community languages. So we looked at the languages that people spoke in this area, and we translated all the material into those languages so that we sort of really had giving people information in their languages. So the parent interactive sessions went pretty well. There was varied attendance. Some centres we had 2 sessions in if they weren't well attended. We gave them afternoon tea. There was a lot of interest in the hands-on demonstration. So we brought all the child restraints out and showed them how they actually work and what each bit is and how you do that. We also offered subsidies. So parents were able to get a really good quality child restraint for $50, and we had 20 available at each centre. Some centres we couldn't actually sell them all. Some we were oversubscribed, so we just moved them around, and everyone who wanted a set got one. And the DVD was received really well. And I think this is the filming of the DVD. I mean, as us being a research study, this was done on a low budget. This is actually my sister's house in Marrickville because it was raining. It was the only place where we could get a car undercover for the day because we couldn't afford to rebook the schedule with the film crew. So, and we used a whole lot of children that belong to our families and colleagues' families. So we've got one of my Taiwanese PhD students' son in quite a lot of the footage. My sister's kids, kids that we dragged in from other places. One of the staff members at work is Portuguese, and he's got very dark-skinned children. So they came in into the shoot as well. So we wanted to have a really diverse group of children that actually reflected what was out there in the community. Because what we had found was that all the child restraint material that we got so far had been white Anglo-Saxon children, and it was completely irrelevant to the population that we were working. This, again, is some of the material that we had developed. And again, just some pictures of children. This is Liz Wilson's kids. These are Lisa Keys, one of our researchers' next-door neighbours' children. So, unfortunately, some of our kids were too old to be dragged into it. So the survey use. For the outcome assessment, we used direct observation of the child restraint use. So basically went out to the centres and did survey. So we had to basically get people as they were pulling into the car park at the beginning of the day. We didn't announce that we were coming. People knew that there would be surveys done, but they didn't know when they were going to be. So we had to have some element of surprise. We had to approach as the car was pulling in, and they talked to the person driving before they could actually get out of the car and adjust the child restraints. And basically what we do is just look through the window. So we had trained teams, and these were often the same stuff that had been used in the community surveys that had been done in the past. They were trained to observe appropriate child restraint. So looked at whether they were in the appropriate seat for age, and also looked at errors in use. And we had the two outcome measures, and we had a bit of trouble with the analysis. In the end, we combined the two outcome measures into an ordinal scale. And then after we'd done the observation, we collected demographic information with an interview. So we had nearly 2,500 cars arriving. There were quite a few people that we couldn't include because there weren't any children there outside the age range, or they'd already been completed. We did have some refusals, but in general, we had participants. I think the response rate was about 52%. So again, that was the biggest issue that we had, was getting a high enough acceptance rate, participation rate at this stage. So 52% wasn't as high as I would have liked, but it was still, I guess. And again, generally, we didn't have 100 out of our 700 refusals didn't get the reason. Mostly it was because of time. People were busy and they were running late. You know what it's like if anyone's got children, you drop them at the childcare centre in the morning. You know, like me, you're always running late and you've got to get somewhere. So that was understandable. So these are the results. It's a little bit hard to read, but up the top here, the key basically goes from the top to the bottom. So the black one over here on the that one pointing at the screen, you can't see what I'm pointing at, but in the 3 years control on the left-hand side, the black is the errors in use. Which mouse? That one? Okay, so this is errors in use. The top one is errors in use and inappropriate restraint. Errors in use in an age-appropriate restraint. Suboptimal, so inappropriate restraint but no errors in use, and this one's what you really want, the optimal. So age-appropriate restraint, no errors in use. And you can see that for each group, it went up from the control and the intervention. There were improvements in each of those. These are the results. These are the odds ratios, and you can see that for all centres, both for the adjusted and the unadjusted, they were adjusted for low income and education level. But you can see that the odds ratio was significant, so 1.64 for the adjusted result, which was great. We found that for families that only spoke English at home, we also found a significant result. Wasn't quite as strong, but for families who spoke other than English at home, we got a much stronger result, so closer to an odds ratio of 3, which was fantastic. And I think that's because we had put in place programs that were translated, and we made great efforts to sort of get to those families. But we also did the follow-up surveys. We had people that could actually speak those languages when we did the follow-up surveys as well. So we actually got a relatively high response rate as well in those groups. So this is for families who speak languages other than English at home, and you can see that there's some quite dramatic improvements, particularly for the 4-year-olds and the 5-year-olds. Not quite so. For the younger children, they're still good. I mean, you can see improvements across the board there. So we had 1,100 families who are culturally and linguistically diverse. That's what COLD stands for. And when we talked to those families, they had less awareness of the new law at the baseline survey, and they had incorrect knowledge about the transition age for both forward-facing child restraints and booster seats, and they had less awareness of the safety benefits and different patterns in access of information. So they're more likely to seek information from friends and families and less likely to use the fitting stations. Now, what I should also say is when we gave people a voucher for the seat, they didn't just get the seat, they actually had to have it fitted by one of our fitters. So they gave us the money, and then basically they had to then go to the fitter and have the restraint installed in their car. So they got the restraint installed correctly in their car as well. It was interesting when we looked at it because most of the people that attended the information sessions were women, but we did get some men attending, and it was one of the issues that we were concerned with is that the women were more likely to attend the childcare centre and take the children there, but in fact in a lot of the COLD families in particular, it was the men in the family that were more likely to make the decisions about child restraints and cars and things like that. So I haven't got any answers about whether we actually got to those families, but it was certainly something that we were trying to address and trying to get a sort of reasonable proportion of men actually attending the information. So we did have a high refusal rate, where there are some limitations, and it's not generalisable to everyone. It's only for children attending early learning centres, so preschools or long daycare centres, and it obviously only applies to children arriving by car. But I think this is a really good trial, and had a really strong outcome measurement. And the program did involve existing services. But also because we looked at both age-appropriate restraint use and errors in use, I think that was the strength. So what we also did, though, and second study I'm just going to talk about, is something that we did, and it was a combination of this study and some of the early work that we'd done, that Julie and Lynn had done on observations of child restraint use in preschool settings. They had done quite a lot of work observing child restraint before the legislation came in, but because we had the control data from Buckle Up, we were then able to actually compare and have a look and see how this worked, but also because we brought the Buckle Up safety intervention in as well, we're able to look at the combined effect. So basically, when the legislation was introduced, obviously the idea was to increase age-appropriate restraint across the whole community, and they were really focusing on age-appropriate use, not misuse. And legislation hasn't always been successful. I mean, other people have found that there's been no changes in appropriate restraint use when legislation is brought in. So what we did was we compared a pre-legislation sample, which was done in 2008, children aged 2 to 5 from local government areas, again in the same low-income areas, to our post-legislation sample. And similar data collection. We used the same data collection methods. In fact, we used, as I said, even the same people to collect the data. We certainly used the same program leaders. So it was a good opportunity to have a look at the difference. So we did find that the odds of being appropriately restrained were nearly 2.5 times greater after the legislation. But also we found that there were improvements in the correct use of restraint as well after the legislation. So before the legislation, we had 50% of people using appropriate restraint, 36% correctly using. After legislation, 74% using appropriate restraint and 46% correctly using restraint. Buckle Up added on to that as well. So we had 82% using appropriate restraint, 2% correctly using restraint. So there was a bit of an additive effect there. The changes to the legislation obviously didn't occur in isolation. So we had big public education campaigns that accompanied that, though questionable about how good they actually were. I mean, I certainly spoke to a number of people in the community who hadn't seen any marketing information about the child restraint legislation. It wasn't particularly done in other languages. They had done a little bit of targeted work with some of the migrant communities, but not a huge amount. But they also had a targeted enforcement campaign as well, so which started off with the police cautioning people, but then also sort of having a bit more of a focus on child restraint. We didn't expect that there was going to be an increase in correct use after the legislative change alone, and it's not really clear why that's happened. The marketing certainly wasn't really focusing on that. It might have just meant that people were going to see restraint to get their restraints put in when they bought new restraints. They were getting put in the right one, learning how to use them. But we did find that the legislation worked, and with the community level education, it did increase the optimal restraint use in low income areas. But we do need more work in that area. I think it also showed the benefits of the Buckle Up trial over and above the legislation, showed that you do need to have more work done over and above just having simple legislation and the education campaigns. Having a targeted program certainly was very effective, but certainly for the people who didn't speak English at home, and I think that was tremendously successful. We've had a lot of demand for the resources across the state governments. Now, the state government hasn't stepped in and funded the program, unfortunately. But they have requested the resources. Several of the other state governments in New South Wales have also taken the program and adapted it. So they've taken the DVD, they've taken the materials. The DVD, I think, is being redubbed into other languages as well by one of the state governments. And that costs quite a lot of money. And we hadn't done, I think ours was only done in English, but they are actually dubbing it. And I think there's 3 states that are taking the material and using it in their community settings, which is fantastic. We also piloted, though, the Buckle Up program in community preschools with a high Aboriginal population, and we showed that worked in that community setting as well with minor adaptations. And we also trialled it in Aboriginal medical services. So these are community-controlled Aboriginal organisations that deliver healthcare services. What we've now been funded to do is do a step wedge trial of the program in Aboriginal community settings. It'll have to be slightly different, but what we were originally going to do in Aboriginal medical services, so they're like general practices that also put out health promotion programs. But because we've got another driver licensing program that we're running at the moment in community settings, we employ Aboriginal youth workers to deliver a driver licensing support program. Buckle Up is going to sit under the same umbrella as that program. So we basically will be employing an Aboriginal community worker who will be training, who do training in child restraint installation, but we'll be delivering these resources in Aboriginal community settings, so preschools, the Aboriginal medical services, and then we'll do the same observations at 3 different time points across the 12 sites. So that's commencing in August, and we're just looking at materials at the moment and adapting those for those community settings. But again, with the Aboriginal community program, what's more important? The resources are important, but again, because the resources were developed for the broader community, we think they're actually, the Aboriginal community people that we've tested them with have said are perfectly happy with the resources. The DVD is a very straightforward one, and that's been very well accepted by the Aboriginal community. We don't think we need to adapt the resources much more. It's about the delivery of them. And for the Aboriginal community, that's being delivered by an Aboriginal community member in a setting that people are comfortable in. So rather than, asking people to go to the motor vehicle registry or to a restraint fitter that they're not comfortable with, they're delivered by an Aboriginal community person who will then broker the appointment with a restraint fitter or do any of that kind of work that needs to go on. So just trying to break down the barriers. But again, the challenges that we've had in the Aboriginal community setting have been largely around lack of access to private vehicles, the fact that people are moving from car to car, and I think with the current child restraint design, that's very difficult to get away from, because even our booster seats now have anchor points as well. So we don't have that click-in system that you have here. We have you've got to fiddle around with the seatbelts and with the anchor straps and have everything sort of put in place. And if with older cars that many people never have sometimes do that. So that's certainly going to be a challenge going forward. So I do need to acknowledge all the staff who participated in all these studies and the childhood services, but we did have a big group of collaborators. And you'll see here again, this is some more of our diverse group of children that we included in the study. That's my niece on the left and a few of the other kids from one of our staff members there. So I think that's all I've got on that. I have whisked through this very quickly. So has anyone got any questions? Yes.
Fascinating. I'm curious, the education about child restraints, was it focused on adhering to law? Was it focused on making kids safe, some combination, and get a sense of what resonated with?
It was really focused on explaining to people, well, it focused on telling people what the new law was about, because people didn't understand that, but talking about why the new law was there and why people needed to keep their kids safe. So the DVD, for example, focused very much on why you need to have how child restraints work. So it actually showed, pictures of the bony skeleton and where the seatbelt sits and what happens if you don't have a child restraint. So the crash footage with kids submarining and shooting across the car. So, and that was actually very good. But most of the presentation focused on the safety aspects of it rather than we had to include the legislation in so people knew. With the question and answer discussions, though, it did depend on the audience, but generally people were concerned. We had to really shut these conversations down because they happened all the time. People who had children that sat outside of the norm and didn't fit in the seats. So we always had someone who had a very large child that didn't fit in the right seat, and that's changed now because we have bigger child restraints that have just been sort of brought out. But people had very specific discussions about their cars and, we have issues with the child restraints not being able to fit 3 in a row, generally to do with multiple families and small-sized cars, and how you actually can fit kids in a car with child restraints. But the material was really focused on the safety aspect rather than the legislative focus. It's hard to know. I mean, obviously the enforcement angle always works. I think they did talk a little bit about the fines from that, but most of the presentation was around the safety angle.
Yeah, because what I was thinking of that prompted that question, study years ago on fails back in China, they were finding that minority populations were much more responsive to change in law.
Yeah.
And they weren't sure if it had to do with being more law-abiding.
Yeah.
They were more concerned about being at odds with law enforcement
Yep.
or with fines.
Yep.
But that I was wondering if
Yeah.
there were differences.
Yeah. Yeah, I couldn't tell you from the people who didn't have English as a first language, but certainly we thought it was about giving people information that was targeted at that group in a language, in the right language. I mean, certainly the parent workshops were delivered in English, but we did have people available to translate if need be, only members, but in the yeah, I mean, there were we had a few populations. We had a few groups who we had a few people who spoke Dinka, and we had in one area of southwestern Sydney, we had a group of ethnic Chinese people for whom it was very difficult to actually find anyone, and they had very poor English, so trying to translate the material for them, we couldn't do it. We couldn't do the written one because it was only a couple of families, but even finding someone to help translate was difficult. So we did find someone, but we did sort of go to some links to make sure that people got information. And I think it's hard to tell though whether it was the legislative focus. Certainly people didn't have any really understanding of what the law actually meant. People were concerned about that, so I'm sure that had some impact. It'd be interesting to do it again now. You know, do it 5 years later once the law has been in for quite a while, and just see if we can actually, if it has the same impact.
So I think parents have somewhat changed their recommendation from rear-facing for rear-facing. So I guess I'm curious in the sense how impactful of a change that safety, or like how, the guidelines are 6 to 9 months,
Yep.
and also related to that, I guess it's more of a context. I mean, even as a parent, it's hard to, I can see why it's complicated. So many kinds of seeds and forward, and then the guidelines change, the law change. So it's kind of like it's a moving target, or it could be this law.
Yeah, I mean, in terms of the child restraints, we don't have rearward-facing ones. Are only used in Australia for babies up to 6 to 9 months, and I don't think that's going to change. There's no real move in Australia for that to change. So that would require a huge cultural shift in, what people think of being safe. It's just that rearward-facing thing. I don't really understand why there's such a big difference as well. But,
I guess I'm thinking too about like how these things kind of evolve. The products on the market. It sounds like mothers have interaction with grandparents.
yeah, there were grandparents at the sessions.
They react differently
Yeah.
because technology is so different.
Yeah, I mean, we worked, and certainly with some of the qualitative work that we've done in some of the other settings has been with grandparents. And there's a bit of there's some really interesting stuff, and I'll send you the papers when they get published on the qualitative work. But really, it depends. So in some cases, people are saying they get a lot of resistance from the grandparents to get the kids in restraints. In others, it's the grandparents actually laying down the law and saying this is really important, you've got to do it. So it actually really varies very much from family setting to family setting. But it was a very overwhelming comment that the care, because we have a lot of kids that are cared for by grandparents, actually discussions on how you do that. A lot of the new child restraints are actually installed in the grandparents' cars who were with their children, because families were perceiving that could be easier rather than moving them from one car to another. But I mean, again, a lot of the issue. I think there's a real market for development of a safe, low-cost, easy-to-use child restraint, because again, a lot of the market now is on these very high-end, big maxi things with drink holders and all these little armrests and things like that, and they're heavy and they're really hard to move around. I mean, certainly with our work in Aboriginal communities and some of the work in Southeast Asia. Actually, if we could go back, I mean, I really loved the foam booster seat that I had when my kids were little, which you could just shove in the car and belt the kid in. And you can't tell me that the high-end one that I bought, which was $400, it was built. I don't believe that you get many more safety benefits from that restraint over and above the foam one. a well-fitting foam one. And I think it's a bit of an issue of marketing combined with safety, and the guilt of parents is that we end up with these really high-end and quite impractical systems. So now the market's sort of come back to these narrower seats, so you can at least fit them in the car. But actually, I think there's a bit of an opportunity for someone to go out and develop a sort of high-quality but low-cost and easy-to-use restraint. Yeah. Yep. Always graduated earlier. Yeah. So kids, not so much. We didn't look at the babies, so we didn't have infants going into forward facing, but definitely kids and it was very common that we had kids who were 2 or 3 in booster seats. In fact, that was I think my kids moved from the forward-facing restraint into a booster seat at age 2.5, something like that, which is, and that's very common. So kids moving from that into a booster seat, and then from graduating from a booster seat into a child restraint, into a seatbelt at sort of age 4 or 5, very common.
I was curious to hear whether you saw any correlation.
We have very high feet charge, so it's not even an issue for us. Our restraint is close to 100%, so it's not something that we ever really look at because the restraint use is so high, particularly for parents with children. We didn't look at it.
Is there a primary capability? I think the DA involved in how what sort of what the thought process was provided, whether it's sort of the law.
Yeah, well, in this case, we actually picked the person who was involved was the person she was the director of the Centre for Road Safety, which is the main road safety arm of the Road and Traffic Authority, but she had been she'd been working on child restraint for years, so she was definitely very much on that, that side. We have had more challenges in trying to get it through at the other end. And again, it's about turnover. Unfortunately, that lady passed away a couple of years ago, so we kind of lost, and they've had a lot of turnover in their agency. So I think one of the things, and what we're doing at the moment with some of our, so for example, for my Aboriginal driver licensing program, I've got a lot of stakeholders on that committee. So I've got maybe 15 different agencies represented on the steering committee of that study because it cuts across a whole lot of areas. But I'm very focused on keeping the stakeholders current and moving on to the right person. If one person sort of comes out, quite often with policy people is that they move into a different content area, but they hang on to their committee membership on your study because they're interested in it. We've been kind of trying to move on to the right person. So we're always keeping, and I talk to the ministers about the studies as well as much as I can as well. So we keep the politicians on side as well as we go to try and make sure that we are keeping everyone happy and maximising the chances of effectively implementing. Yeah. Absolutely, and that was one of the issues that we were dealing with from the very beginning with this one, and I absolutely agree, and I don't really have an answer for it, and that's certainly some of the feedback we've had from the agency is about the cost of these kind of programs. I think my feeling is building it into existing programs. So the idea of this one that it was built into kids in traffic who are funded to deliver road safety materials to school. So one part of it is actually covered, and they are, I shouldn't say it's dropped out, they are still delivering that program. So they are giving that child restraint program for long day as well. So it is actually ongoing. The parent workshop bit isn't, and the subsidised restraints. I mean, really, my feeling is that as things change with the legislation, programs like this probably don't need to be funded forever at this kind of capacity. So it'd be nice to actually see a program like this run for 3 or 4 years across the whole community, supporting low-income people to actually get into restraint. But I think once we actually develop a reasonable amount of community capacity, one of the things that we have really, I guess, uncovered with some of the qualitative work is that the understanding of why you would need to put child restraints in kids in child restraints wasn't really there, and getting people used to the ideas of having child restraints. And once people accept that that's what you do, this is what you need to spend to get that. And there's a reasonable number. I mean, there always seems to be child restraints floating around in the community as well. Not that you should be really be moving child restraints from family to family, but there can be, you get a bit more capacity and you get more seats around and people understand it. So you might not need to actually push it so much in terms of actually funding it. I mean, that's my feeling. I think you build up to a certain level of capacity and then it can be maintained by standard enforcement and community education programs. I see it as a little bit as being along with the driver licensing issues with disadvantaged groups, which is actually because we don't have a whole lot of people who can do supervised driving practice in some of our disadvantaged communities. But once you actually change that expectation that people and get people to actually act as supervised drivers and you change the culture, you don't actually need to spend the money to push for that because it's actually you've built capacity in the community. And I see that a little bit with the child restraints as well. I don't think we're there at the moment. We're struggling. I mean, as I said, we've got funded rolling forward. So it is the most frustrating thing about being a researcher is that you do these really high-end costly studies and then you sort of come out at the end and go, well, that was great, but no one's going to fund it. So, have we just wasted our time? I think the lessons that we've learned, though, is certainly that having targeted information for the non-English speaking families is really important and does make a difference. That is also being implemented in the state government as well. So they are spending a bit more money on that as well at the moment. Intervention, yep. Well, I mean, the control group, if the control group, what we were worried about was contamination with the control group because we did the baseline survey of everyone and we asked them about child restraints. But that was, because the legislation was being introduced anyway, and it was just a self-report survey at the beginning and we didn't tell them that there was a big study going on. If anything, what we were worried about was that we would see no effect because the control groups would actually start using child restraints if we talked to them about child restraints, even the very fact that we did a self-report survey. But, I guess you could say if that happened, we might find that, we underestimated the effect of the intervention. It could have actually been even stronger, but I don't think it would have gone the other way. What we were concerned about is that, again, that we would get increased restraint use when we started doing the surveys at the end. But again, the control group were similar, so they could have, it should have been the same. We wouldn't have had a differential effect, so I don't think we would have got any bias there.
Like, I don't know about possible parts engineer, especially with the
yeah, I think they are. So I think Volvo had a car with a booster seat built in. Yeah. Yeah.
Yeah.
Well, it's also a practicality thing because they've got to be able to be moved. You've got to be able to revert back to a normal adult seat. And also kids are a whole lot of different sizes and shapes, things like that as well. So again, it's booster seat, conceivably, yes. The forward-facing child restraint. Again, it's that whole thing of building in a system that they have to be. I mean, you know, even we really down on those restraints. I think what the word is, you know, where you move from the child one to the forward-facing one to the booster seat one, and you've got to modify them. Yeah, the convertibles, and you've got to move the straps around. I don't know if any of you have ever done that, but I just find that a complete nightmare, even as a sort of, you know, well-educated person who's reasonably competent. I would sit there for hours going, bloody, this is almost impossible to do it. So you often end up with, you know, how anyone can do it. You know, those kind of, but it's likewise with the car things. If someone has actually got to actually do anything to it, and it's so that you're not having to take it to an expensive car person to get it changed over every time you need to change it, then it becomes a bit more of a liability than anything else. No, I haven't seen that. No. Really?
For airport.
Okay. Okay.
But it's just a little tiny.
Yeah. Full booster. No. Yeah, I mean, it's an interesting thing because, I mean, car safety is changing dramatically, and I think in the next, probably what will happen is that cars will become so safe that they crash so infrequently that the whole issue of child restraint will probably become far less important than it has been today. Well, but see, we're working in a challenging environment. I mean, it would be the same here in very disadvantaged communities. We're actually just getting, I'm challenged getting kids in some communities into adult seatbelts. And most of the benefits, if you look at the child restraint research, most of the benefits you get go from wearing nothing to wearing something. So most of the benefit, I think something like 80%, I can't remember off the top of my head, but it goes from, you know, 80% of your injury goes just from putting on an adult seatbelt. So they work so effectively, even for quite a small child. So I know with the Aboriginal communities that we're working in, you know, you've got 20 people in a car or 15 people in a car. I'm actually we sort of try and institute a rule of one person per seatbelt, and then moving on to the child restraints for kids will be a kind of, you know, I mean, you want to get kids in child restraints, but you've got to actually start from. And a lot of our low-income families that were in this study, there were quite a few families who were challenged as well. So you would still see the kind of van with 6 kids floating around in the back, and not all in any kind of restraint. So I mean, it's not that uncommon. It's more that would freak me out more than it might to you, because we do have primary enforcement of seatbelt laws, and seatbelt wearing rates for adults in Australia are 95%, I think. So, you know, the concept of people not wearing restraints, you know, you just go, oh my God, it's not wearing a seatbelt. It's a bit like smoking for our kids. They go, oh, look at that person. Haven't got a seatbelt on.
Do you prohibit riding the back?
Yeah. Only recently, though, and it's only just been a really recent change. It's certainly prohibited for newly licensed drivers. I think the law's just changed for other people as well, but it's only been, if it has been changed, it's only been very, very recently. So.
They're rear facing.
Yeah, rear facing too, so really great. Yeah.
Okay, well, thank you very much.
And don't forget that Rebecca's speaking again tomorrow at 12 o'clock on her Aboriginal work in room 2106 in this building. So just upstairs.